Demand is rising, budgets are tightening, workforce shortages are growing, and the complexity of need continues to increase. Many councils are struggling to deliver even the basics, let alone innovate. This panel will explore the structural and financial pressures driving capacity challenges, the impact on service users, carers, and community, and opportunities for reform through integration, prevention, and digital innovation, and what councils need from central government partners and each other to move from survival to sustainability. So let's introduce the panel for you. Ian Turner, OBE from National Care Association, Hulya Mustafa, Director of Digital Policies and Programmes at the Department of Health and Social Care, Lee Rickles, Chief Information Officer at Humber Teaching NHS Foundation Trust, and Jane Brightman, Director of Workforce Development at Skills for Care. So to all of you, but maybe Ian, if you can start us off, just give us an idea of what the structural pressures are that are facing the services and what the current capacity crisis in crisis in adult and children's social care looks like.
I think we've got to start with basically saying how we've structured services in social care over the last 20, 30 years. And that is taking an approach which encourages private providers to actually step in and make investments over 20 years usually to actually provide services. Now, that has changed fundamentally over the last 20, 30 years. Sorry, I've been a provider now for over 40 years. When I first got involved in the sector, we were looking after people with physical disabilities, and we're now in a position where we're predominantly looking after people who are very frail, who would have been considered to be under the care of a geriatrician 40 years ago. And the vast majority of people are those people living with dementia who need a completely different level of support and skills that allow us to support them to live lives as they choose. It's not like elective surgery where we're actually looking at somebody who's needs a cataract operation or another intervention. It's ongoing support. Now, how do we actually do that? How do we bring in prevention? How do we bring in integration into those services so that we're not having to move people from physical location X to Y, because if they're in a care home, then that is their home. And how do we actually manage the services with virtual wards, technology increasingly being used to make sure that people do remain in their chosen location, but at the same time be able to deliver services to them. So there's financial pressures in terms of people investing over that long period of time to enable those services to be there. The biggest challenge at the minute, and has been for a number of years, is how do we actually staff those services, and what skills do we actually have in the workforce, which has changed fundamentally over the last 20 years.
That seems to me to lead nicely to Jane.
Yeah, absolutely. And as Ian was talking, I was thinking about the workforce and the more recent issues, I think, around international recruitment, tax being turned off, and so Skills for Care captures the workforce data for England, and we saw really good growth in kind of our workforce, less vacancies, but we're starting to see that now turn back down again as those taps get turned off for the sector. That's really challenging. And then as Ian was saying, those financial pressures, national insurance, pay rises, which are vital and really important for the sector, because we know a lot of our workforce are living in poverty, but it's really hard on providers, and we've got the Fair Pay Agreement coming at some point, which again will hit providers, really important for the workforce, but it will hit providers. And then we've got things just like our basic demographics. So our workforce is predominantly female, 45 plus. So we have a lot of kind of workforce issues that face them. menopause. Often they're sandwich carers, so they're looking after parents, they're looking after children. Lots of issues there that our female workforce faces. So it's a bit of a perfect storm.
Lee?
Yeah, so I think obviously we've got a high level of capacity issues with staffing, but we're not being able to sweat the advent of new technologies or how we can share information effectively to really at least help support the capacity and capability we've got, whether that's the domiciliary carer, the nursing home qualified, or even when you get into that weird word of the NHS, because there is a very different language between NHS and social care, which can create a very convoluted and difficult conversation. So because the ability to share information can be quite challenging, if it exists at all, it means the people who are providing care, including the carers themselves, the unpaid carers, they're most of the care provision, find it really difficult to understand how to access services, how to communicate with others, how to share information, and how, when they do have information, it's actually acted upon. So, a certain a person may well have information, but the massive frustration is nobody's listening. And it's not, and it might be available, but it's not being acted upon. This also links down to the digital literacy and also digital poverty as well. It's okay saying we need to really join technologies up, but again, in a vast majority of cases, there are financial constraints, and also a lot of VCSE third sector are basically paper-based for healthcare records as well. There's some good stuff that the Department of Health and Social Care are progressing, but it's progressing. Paper is still king in a lot of home-based care situations. So there's still massive opportunities, but again, that massive opportunity does require a massive change in how we operate as a community and work around the person and the carer, and less around siloed organisation and contracting. That's an easy one to say. I'm speaking from personal experience with my parents, where it's hell, and I'm in the system.
Yeah. Hulya, just moving on a little bit, given what we've just heard, how can digital and data shift the system from this sort of crisis response that we seem to be into something that is a bit more proactive and preventative?
Yeah, and I recognise the points people have made. I mean, there's increasing complexity, increasing kind of demand generally, and pressures on the workforce. So all those things are combining. And I do think I'm not going to sit here and say digital and tech is a silver bullet, which people like to sometimes say. It does require, as Lee says, it does require embedding. We can have these tools, they can exist, but actually getting them embedded so they're making a difference to the workforce's lives and to people's lives is also a project in itself. So I split it up into three things, right? There's digital, which is the adult digital social care record, which the department is rolling out. We're up to sort of 80%, aiming for 90%. I recognise that still feels like a lot of paper, but a lot of providers are using the digital social care record. There is a function in that which can connect to GP health records as well. And we're encouraging all providers to switch that functionality on if they're using a social care record, a digital social care record. So we are getting to that place where a care provider can see more information about the user. And then the other digital kind of innovation I would talk about, and Lee just mentioned it there, is like local authorities are increasingly digitizing their front door so that people can self-serve, they can triage, they can kind of put in what they think they need and be directed to the right place or be offered the right level of service. And that's great because either somebody really does need something quite intensive and they can get that more quickly, or actually there might be a whole range of lower level, not quite care services the community can provide or the local authority can provide, which takes away from immediate care needs. So that's digitization. There's data, which will come later. Once you've digitized, you have lots of data. We can talk about, how you use that to plan services and commission services. And then there's the actual tech. And some of that is really quite exciting. So there's falls prevention tech. The department's been funding some pilots about falls prevention, and it can reduce falls by 50%. So you might have, for example, a smart light. Can I go on, Tanya? Don't start making,
No.
funny to wind up. So a smart light, somebody sits up in bed, whether it's home or a care home, and the light will sense that and switch on dimly. If they stand up, it brightens and lights their path to the bathroom. It will then send an alert if the person stands too long in the bathroom or leaves the room for too long, according to their own personal patterns. If they fall, it will also send an alert. And somebody in a control room can see. And that means staff don't have to keep checking. It means the family get a quick alert about what's happened. And it can also, it records the if there is a fall, it records what happens up to that fall. So you can see what happened and is it a loose carpet tile? Was the slipper too big? And you can prevent another fall. So, things like that are amazing. There's another one where we're using Alexa to try and help people live more independently, or there's sort of, what do you call it, non-intrusive monitoring, right? So you can monitor someone's patterns around their home, around their room, and if those change, there's an alert. So there's all these kind of techs, and what we're trying to do, the department, is make sure we have the right evidence and the right kind of guidance for suppliers, what we're trying to look for care providers, but also for care providers buying them.
So how does this all work in with budgets? Because money is always tight. It's getting tighter, it seems. How are they trying to deliver this kind of level of social care, and where are the financial pressures, do you think, most acutely felt? Should we start with Lee?
So from I think the issue on the finances, I'm really talking from. I'm really on because we provide shared care record and information to VCSE, third sector, health, social care, and that is read, write, two-way communication in our region. It works quite effectively. Is it perfect? No. Does it save a shed load of time? Absolutely. Is that with a patient? No. So the reality is health is far better funded than social care. Definitely compared to VCSE and third sector. So the partnership that we formed basically cross subsidises everybody. So we do not let people fall through the cracks because a local authority doesn't get the funding, but there is funding in another part of the wider system. Something, I'd say it was like in the integrated care systems, but we are a Yorkshire and Humber footprint, not just an integrated care system footprint. So it's that pragmatism, because realistically, when we're looking at the outcomes for them people and their quality of life and care, that impacts everybody in that provides that care and that support rather than the silos. So the way we've dealt with it is it's a shared responsibility and it's a shared budget overall across the whole partnership, and it's used where it needs to be used rather than where like an acute might want to spend the money on its own, irrespective to the impacts that might have on the social care if you was looking like trying to place people and discharge them out of bed. So and we have got some really good evidence of where that's saved time and effort. And the real positive is we have built standards, international standards, with the adult social care teams. So it's speaking in the right language as well, because there is a very different language with social care than there is health. But again, they need to work together because there's always these contact points. So it's trying to work for the benefit of the patient rather than the benefit of the organisation. I think that's the way I'd say can work. But you've got to have a particular mindset for that to be effective. It doesn't work too well in very tight, tough financial environments unless you've got some very enlightened leaders to help you on that journey.
Ian, when it comes to budgets, where are the real pinch points, do you think?
I think what we've got to accept is that our systems in social care are totally different to the systems that are available inside the NHS. And some of those systems we have tweaked to allow social care to actually access that data. Now, my overall point is two of them really. We need to sit down and actually look at the architecture of these systems, because all the acutes are running different systems. The GPs have got a couple of systems, yes, but how do we integrate and make interoperable these different systems across multiple suppliers? That's one issue that I think we do need to spend more time looking at the architecture of that. And as Lee says, the absolute fundamental there is standards. so that we are actually storing data in a standard way across the entire system so that we can all understand what it actually means. Now, that's quite difficult to do because you've got all the specialities within health that use different languages, not understood by carers necessarily. In fact, in the vast majority of cases, it isn't. And so actually standardizing that, and the work that PRSB have been doing over the last decade almost, is absolutely vital to me. Second thing is, back to the actual funding bit, we are frequently asked to adopt Tool X or Tool Y, be it on Falls or News 2 or whatever other facility there is there, that we are not being paid for, and is an overhead to social care in actually being able to collect that data. And somehow, building on what Lee said, we need to get over this to the point where we've got a funding model that actually accepts that that is the situation, and that we need to be doing in social care a lot of the OBS that allows the GPs or the health specialists to actually understand what situation that individual is in, and consequently be able to prescribe the correct sort of care plan. So I think they're the two structural things to me. Making absolutely sure that we've got the systems and the standards in place, and find some way of actually not just. I don't want to use words like pooling budgets and what have you, or yeah, it's we've got to find a practical way that these systems are actually supported in a financial sense, both from a technical point of view and the staff. Sorry.
Do you want to pick up on the data sharing point? That you sort of hinted at it in your first answer. You may as well pick it up and run with it now.
Yeah. So I mean, everyone across health and social care programs in the department, really want to sort out the architecture and the data sharing. So the 10-year plan talked about the single patient record. I think the digital social care record provides a really good foundation. And actually, whether you were trying to say this or not, Ian, I mean, social care is in a really good place digitally, actually. Like NHS struggles with these huge duopolies or monopolies of all their electronic patient records. And actually, social care sector has been much more nimble and has the digital social care record is much more flexible. And so actually the single patient record, I think, is going to be a really good place. And I think neighbourhood health generally, and I know, I've worked in this sector like 10 years, and we've talked about integration, whatever. Neighbourhood health is yet another chance to really try and join services up and really understand the value and the cost between the sectors, to speak as a similar language, to have similar systems that at least join up. And we're working very hard on interoperability, making sure our data standards are understood so that social care providers don't get tied into a certain social care record provider, and all those kind of principles are actually being now listened to on the NHS side, because they see how well it is going in social care to have a proper market, and where we set the standards, and then actually those suppliers do follow those standards to make sure that the tool is useful to the sector, not the other way around.
Lee?
Yeah, thank you. So yeah, absolutely. What I would say is we've been doing that for the last 4 to 5 years already. The Interweave solution is a vendor agnostic solution. It basically creates the 3-pin plug that you plug into the different EPRs that are out there. And you're right, Ian, there's too many, and they're not very well constructed in a number of ways. Also integrates into the new social care systems, as well as the existing candidates that are more local authority based, and that is working well. And that's where the standards that are being, so there's an international body called HL7 that basically has the oversight of messaging standards. That's where we've co-designed with social care the range of social care standards that are now available and are available internationally. So it is actually happening across 10% of only 10% of the population of England, but that's the only area where I've got that coverage of that vendor agnostic open source solution, and that system is health and social care owned. It's not health owned, so the focus is very much around the user, not around the technology. So again, them examples do exist, and I do know the CPIS because that's the same technology that the CPIS is being based upon at this point in time. Social care information platform. Yeah, so I'm saying they do exist. So let's not say it's not all where there are some lights at the end of the tunnel. The issue is how do we sweat it, and how do we make sure things like the social care information platform and the single patient record, and however the NHS app works, if it becomes user friendly, actually can coalesce together to really add value and focus around the user. Thanks, Tanya.
Jane's just sort of nodding along with all of this with eyebrows raised at time, I have to say. Would you like to chip in?
Yeah, so I was thinking I totally agree with what you were saying, Hulya, about neighbourhood health being that opportunity for us to bring health and social care much closer together, and how much more nimble social care has been in terms of technology and digital. But I do think we have to work hard at doing that. The opportunity is there. There is lots that health can learn from social care in terms of being nimble and putting the person at the center of tech, and all of those kind of great things that we do really well in social care. But often our voice is not heard at the table. It's often health that's deciding where neighbourhood health will go, 10-year plans, etc., etc. There may be a token social care voice that can sneak in there, but we're still not listening to the experience and the expertise of adult social care at kind of national government. So I think the opportunity is there, and I totally agree with you, but I do think we've got to get better at putting the two together. And then, Tanya, I was just thinking about the workforce lens on all of the conversation that we've just been having there about technology and data and dare I say AI. And there's something about how we support the adult social care workforce, which is bigger than the NHS workforce, and spans a lot more kind of people and roles. And one of the things that we've been doing across the sector, and the National Care Forum have led this, is a new role in adult social care called the care technologist role, which will be added to the care workforce pathway by DHSC soon. And that's a role that we think will start to bridge some of that difference between health and social care and bringing technology much more forward, helping the workforce to focus in the right areas. But we also think that will attract new demographics into the sector, younger people who want to use technology as part of their role, men. We think that's going to attract a new demographic as well. Ian has waved his hand there.
I just want to bring out one absolutely fundamental thing about the social care sector. We are not 150 trusts spread across England. We are 26,000 registered providers across CQC registered services. And from your figures, Jane, I don't say personally, but from Skills for Care figures, there's about another 13,000 that are unregistered daycare organisations, etc. The vast majority of our providers are SMEs, and by that I mean there's very little management availability, middle management availability to actually implement these systems, discuss them, and actually get involved in piloting them. And that gives us a structural problem in terms of how we can actually bring along those 39,000 services to actually be in some reasonably consistent way. I don't say totally consistent, but reasonably consistent way that we can implement them. We do not have in the average social care service technologists like Lee. We don't have the roles for actually being able to implement change in the system. And it all falls down to this triumvirate of registered manager, deputy manager, and administrator. And consequently, we've actually got to make sure that the implementation guidance, as well as the funding and all the rest of the things, is appropriate for those very small organisations to actually adopt.
Hulya, is that, you're nodding along there, is that something that needs to happen, a standardised system?
So the thing I was nodding along to is understanding that there are a lot of SMEs out there And so, I would hate to be an SME trying to deal with this sea change of technology and the risks and ethics around the use of AI and liability and all that kind of stuff. So we're very alive to wanting to shape the market, both the adult social care market, but also the digital market, like I said, with kind of guidelines, templates, working with NICE on evidence standards to make sure that we're supporting SMEs in this kind of new technological world to make sure that they can make the right choices for them. They're small businesses, they want to invest in the things that are genuinely going to help. So that's what I was nodding along to. I totally take Ian's point on that.
I'm just going to go to the questions that we've got coming in. Joanne Dakin says, what do you think the NHS shunting the responsibility and cost of healthcare to social care and the impact and the role of the local authority to provide preventative and maintenance support in the community? Lee, do you want to pick that up?
I can do, albeit I'm a technologist rather than a commissioner. So I think the real challenge on this one is just the current pressure around all the costs for all the services. We want to recreate a different way of working, as the 10-year plan says. We're going to have the shift from hospital to community. But to do that means we need to have a completely different way of operating. We need to think very differently. And I think that's a cultural change that's going to be really, really difficult, where most of the money is in health, because health does have most of the money. It's come out very, very well. So I think the challenge is going to be the speed and pace, and also the final one, especially from a health acute perspective, is seeing the patients as people and understanding the value they add. And I think at this point that's not the case. If you're on a system call, as I am, I'll be on Sunday when I'm director on call for my organisation. It can be very, shall we say, statistical rather than person orientated. And I think that's the challenge. How do we balance massive deficits, lack of investment, and having to transform systems? And none of that's easy. So not that it's impossible, but it does require a significant level of joint working that we have not achieved yet.
Jane?
Yeah, and I think part of what Joanne's talking about there is delegated healthcare, which is coming at adult social care really quickly. We are developing support and guidance for care providers, but it's a tricky world. We can see the benefits, but the funding isn't following, and the training and the supervision from clinical staff isn't following. So adult social care workers are being asked to pick up delegated tasks that they're potentially not trained or supervised to do, and providers aren't getting the funding to be delivering those things. So we can see the benefits, but we haven't got the model right yet.
Hulya, I think this question is probably directed at you, from Dylan Roberts. It is not true to say social care records are in a good place. There are limited standards. The systems are legacy and old. A lot of the data is qualitative and not coded.
I think everything's relative. I think there are benefits to the social care records that we have compared to some of the NHS records, which is what I was saying. And yes, we're on a journey with social care records. We want them to go further. We want them to be better. We want to increase standards. The first push on our program was to get people to have some kind of social care record, and we've done well on that. And now, it's a constant journey. It's a constant evolution. So everything's relative. Things can always be better, but I think they're in a pretty good place for where we started.
Joe Johnson says, what do you think the role of adult social care and hospital discharge in promoting and supporting productive, healthy ageing, i.e. financial security, purpose, connectiveness, resilience, etc., which can lead to healthier and more active lives and reducing the need in the long term? Jane, you were nodding. Do you want to pick that one up?
Yeah, absolutely. I think it goes hand in hand with the delegated healthcare side. I think what it's saying is, and what Joe's pointing at here, is adult social care is the key to a lot of these issues, and really could solve a lot of these issues and solve a lot of the problems that we know the NHS is struggling with. But again, I go back to my point, it doesn't have the seat at the table, it doesn't get heard, the funding doesn't always follow, the training and the supervision and support doesn't always follow. So if we could get the model right, I think, to Joe's point, it could do so much more. Preventative commissioning, loneliness, healthy aging, all of those things it could do.
Hulya?
Yeah, I've worked on hospital discharge, and it is the moment where everyone decides to come round and focus on the individual and try and sort it out. And we've gone from a place where it was very kind of a blame game binary to something that is more kind of collaborative. Okay, but it's still wrong that it takes that event for people to come around the table. And my hope would be with neighbourhood health and with more kind of data sharing and more digital access to information, services could gather around an individual before they had gone into hospital and were coming out, and everyone was a bit worried about where they were going to go. And actually, you could have those conversations much earlier in a preventative way, because something that a social care worker had noted on a visit could then be flagged with a GP or flagged with a family, etc., etc. So the hope is that we don't have to have that, but I do think it's a much better position at hospital discharge than it was like 5 years ago, where people were just always scrapping and trying to wash their hands even at that moment of crisis.
Ian, did you want to come in?
Just want to mention information, advice and guidance, and come back to the fundamental about the public's lack of knowledge about how to access the system. Yeah. Lee mentioned it earlier in a personal capacity, and I'll certainly add another example in there. My own partner, my own wife, is living with multiple sclerosis. We've actually got a neurological nurse that works in this area, where I can go to that individual and get advice. That individual has got access to the consultants and the GPs and is a prescriber and. Understanding what is available in a local area is absolutely fundamental. And therefore when to go to the GP, when to go to a different specialist, how we access the services. My personal view is that there's an awful lot of work that we could do, both from a local authority point of view and from an NHS point of view, that would help people understand better what the situation is. Somebody's diagnosed with dementia, for example. There's not a great deal of services that can actually they can access. One of the things that we want them to do is to actually document the life history, because if there's one thing that actually allows us to provide more appropriate care for that individual, it's understanding that individual in detail, what their life, what their occupation was, what their interests are, what their hobbies are. And therefore we can engage with those people in a far more meaningful way and give them a much better quality of life. Now, so I think information, advice and guidance hasn't been a very successful part of the Care Act, but I think we need to adopt that across both health and social care, to actually try and get the general public to understand better how to access services and what's the appropriate time to actually make a referral.
So just moving on from that, how can we deal with cases better? How can councils, healthcare providers across that whole sector deal with human beings better, do you think, going forward, in a way that is not going to cost us, heaps of money that we don't have?
I personally think that we've got to actually start looking at pathways. I know pathways have been used as a word over the decades, but I honestly think that we need to actually write up in words that are understood by the public, about how they can actually access services, and if they're in this situation, then that's the more appropriate way to access support. And maybe we've got to get some books written, and maybe we've got to document some of the high-profile cases that have been in the press, and get people to actually write books about. I'm just looking. I haven't got it on my desk at the minute, but there's one gentleman that lived with his wife, who was living with dementia for about 6 years in a care home, and has written a book about what he found and what changes we actually need to make, what his experiences were. And it was all about the individual and what that individual wanted to how they wanted to live, basically. So I think there's a lot more that we could do without spending a vast fortune in money. to actually try and get a layman's view about how to access services when you're trying to juggle 3 or 4 serious conditions in later life.
Hulya?
Yeah, and actually this comes to Dylan. Dylan had a point in the chat as well about the whole circle of care and families leaning in, and we talked about unpaid carers. And it's just a really difficult sector to tackle, and it's something I think it's very lonely for people, and it's something that people don't think about until they're kind of faced with a very difficult need that they're trying to manage. And so I spoke a bit about local authority front doors, and I think there's a lot more we can learn about helping people get to the right place and triage, and not being precious about, well, if it's not about the thing I'm providing, then I'm not going to give you any information. But actually, well, here's the stuff I can provide, and you might have to pay for it, it might be free, but actually here's something that your local NHS will provide, or here's something that the community will provide. And people are happy to self-serve and go anywhere for these things. But often it's the first time they've dealt with this, and they don't have any peers or anyone who can help signpost them. So yes, to Ian's point, people have trodden this path before, writing books or whatever, but that to just be able to list the kind of things that are useful. I mean, the alternative is on the tech side is that people will just kind of go on Amazon and try and buy something, or do you know what I mean, that the market will try and sell them products which may or may not be the right thing for them. So I would rather there was some kind of triage or guidance via a local authority or a care provider that kind of really helped people understand what might help them, because we do have that information, rather than leave it to themselves to kind of look at whatever Amazon reviews.
Lee, did you want to come in?
Yeah, if I can do. I think the Amazon reviews is a really good example, for instance, on the internet. So let's not be naive. That is already happening, whether it's health or social care. The issue we've got at the moment is we can create a completely separate system to what the rest of the world use. So we don't use Google Maps or do or put our information on other services that people regularly access. We create our own ways of routing information, and we struggle to ensure that the quality information we want to provide or redirect to is the one that comes at the top of that search engine, or even if it's people talking to each other, that they actually can help each other, because it could well be next to kin. It could be the person at the bowls club. God, the bowls club is a nightmare for urban myth and legend. But who get it from the internet. So I think we're pretty poor on sweating the assets that are already out there, that people are already using, to make sure we get the right messaging across. It doesn't need to say Hull City Council or East Riding Council or this particular trust. It just needs to be the right information to then direct people to the right place. Otherwise, the first port of call will generally be a GP who just ends up being a gatekeeper, and 9 times out of 10, they don't know either. So they'll end up then fobbing off to another service because they're absolutely guessing. So there are ways of helping ourselves by really understanding our customers, the people we're supporting, and how they operate, and we flex to the way they work rather than us trying to change to how we work. That's got a far better possibility of hitting a mark. Yeah. So I think there's that reality. Build a new system up, they won't come. It'll just spend a lot of money and it will never get used. And we've seen that so many times with digital systems, that lots of money spent on them and are complete failures. We need to be very user-centered design and very focused around people, how they operate, and how we make sure that it does become the top of the search engine. It's just a reality. If I was a commercial company,
we're going to go down algorithms in a minute. I can feel it coming on.
No, not necessarily, but there is something to be said for that. But again, you've got to be careful on the ethics and the bias around some of them technologies and the use of data and AI. So again, we need to make sure it's in best interest and not potentially in supplier's best interest. For instance, is it in the individual? Is that, yeah? There's a whole different bag around that type of stuff, and lots of different views.
Yeah, and the department has a role in the kind of the standards point of that, but not on the necessarily on the search thing. I just wanted to come back on Lee's point there, which is, who do people trust? who are they listening to? Is it Google? Is it their friends down the bowls club? Is it a family member? The NHS is a very trusted, there's a lot of challenges there, but fundamentally it's a trusted brand still mainly. And does social care have that? Is it the care worker who has regularly come in on a lunchtime or whatever, who might be able to help? Or is it that the person sees so many different care workers because the shifts are so different? My point is there's not an answer, but the trust and going to where people are, to knowing where they look for their information, rather than just assuming that if we do something, they will come to it and trust it just because we think they should.
Lee?
But yeah, I just wanted to come in just on we engaged with 8,000 people, some face to face, some in wherever it wasn't one of these special things. It was really online and pubs. I like the pubs bit, but there was the supermarkets and all that type of stuff. And we looked at all the different views of sharing information and who should have what. Social care was really low down the list, and the main reason is they'll take the money off me, believe it or not. So there was a piece of work that we then picked up that was 2 or 3 years ago. That situation has improved, but I think you're right. That trusted bit is why I ask. So health will not have that same challenge, where in social care, depending who asks the money, ask questions may have other implications. So it could actually be a negative rather than a positive in some cases. That's definitely the evidence we got fed back from the public. I'm not saying that's correct. I'm saying that was the opinion from quite a large number of the population that we asked. So there was more likely to trust a pharmacist than a social worker, put it that way.
Jane, can I just bring you back in? I mean, the workforce is at the forefront of an awful lot of what's coming at you. What would they like to see? What collaboration would help that workforce?
Yeah, so we launched the first workforce strategy for adult social care across England in summer 2024, and that was a real system leadership approach. So the sector developed that for the sector by the sector. I think we need more of that, and I think the workforce voice needs to be heard through that system leadership. We're definitely starting to see that now. The group that oversee the workforce strategy implementation, it's a 15-year strategy, brings in health, brings in education, brings in government. So we are slowly starting to see that coming together of the sector and talking with one voice and collaborating around the strategy more. So we haven't got disparate voices all shouting into different areas. We've got kind of everybody pulling together. And I think that's what the workforce needs. It needs that one voice speaking for it, listening to it, feeding its views through, and I think we're slowly getting there with the system leadership, which is really positive in a dark, challenging world, isn't it?
Ian?
Yeah. How do we actually get the regional and local differences again across to the public? Even if you're a registered manager that moves geography and moves into a different part of the country, you will find that the services that are available and that you need to access on behalf of the people you care for are different. Sorry to keep banging on about it, but it is one of the things that we struggle with. Back to the 39,000 services. Where's the information point that actually allows people who have got a vague idea how the system works, how to actually access those services? There's always going to be local variation for good reason, but we've somehow got to find the strands that allow us to access these services and provide the appropriate support and care in each bit of the geography.
We are, I'm afraid, out of time. Dylan Roberts has come back in and said that some areas have got brilliant service directories, pointing us to the Leeds directory, which he says is awesome. So we can all check that out. Maybe that is a blueprint going forward.